This is mainly aimed at considerations for an osteopathic practitioner or other hands-on practitioners as a basic overview of anatomical considerations with respect to eye movement. Now, the main point of this entire project is going to be considering anatomy with respect to motion more than anatomy for anatomy's sake. So essentially having a common meaning or a common meaning network or a semantic network to understand anatomy in relation to motion more than just understanding anatomy for the sake of anatomy. That said, the reality that we're going to focus on motion is related to the observation that as hands-on practitioners, we are observing a patient from the outside. So many of the things that may be going on with anatomy are obscure to us, but motion is not obscure. So those motions that we can identify and assess and test, we can have some inference. We don't necessarily know exactly what's going on, but we can infer things such that when something seems curious, we can refer it out for a different form of diagnostic that maybe we can't perform, or we can understand that something is not safe for us to treat, or we can understand that something is safe for us to treat. So basically, we're going to go over eye movements with respect to the basic anatomy so that we understand what signs may be of concern, as well as how we might look at it and consider it if somebody is safe to treat, how the areas we might go in order to have some positive impact. So the basic aims here, or the main objectives, describe the general anatomy of the extraocular muscles, describe the nerve supply of those muscles, the general vascular flow, and special attention to the areas where an osteopathic practitioner might be able to have some impact. So we don't necessarily need to get extremely granular about all the small branches within the orbit to the extraocular muscles, but we should understand to some degree the areas that we can have an impact if there is some form of pressure that is safe to treat on that region. All right, describe the basics of what is known about orbital lymphatics and describe cues and common causes of palsy involved in those cranial nerves. So essentially what we're looking at is you have six movements for eye muscles, or sorry, 6 muscles for eye movement rather, and 1 muscle for eyelid movement. So the muscle for eyelid movement is the levator palpebrae superioris, and what it does is it essentially takes the eyelid from a down, an inferior position or a depressed position, and it lifts it up. So if your eye is closed, the levator palpebrae superioris will lift it up if all is working appropriately. Then what you have is your rectus muscles, being superior, inferior, medial, and lateral. The superior elevates the eye, the inferior depresses the eye, so superior looks up, inferior looks down, medial brings the, or adducts brings it towards the midline, so it makes you look at your nose. The lateral rectus makes you look away, or abducts, so it makes you look towards your peripheral or towards your ear, whatever reference point you'd like to use. The superior oblique muscle creates what is called extorsion, or external rotation. So if it is able to act on its own, it will spin the eye out or away from midline. The inferior oblique does the reverse, so it is intorsion, or internal rotation. So if acting on its own, it will spin in. Now, it will be freely admitted that under some circumstances, when the eye is in a slightly different position, altered position, the muscles will have some other effect on the motion of the eye, or compound effect when they all work together, but we don't absolutely need to spend a ton of time on that, primarily because if we have reason to believe that there's a problem, we are not necessarily, as hands-on practitioners, the best people to do something about those particular muscles, but we can identify them and possibly provide some insight to another practitioner prior to the patient presenting upon referral. But what we want to consider is the nerve supply here. So before we move on from this, we're going to consider the nerve supply. So you have 3, 4, and 6, cranial nerve 3, cranial nerve 4, and cranial nerve 6. So cranial nerve 3 being the oculomotor nerve. Essentially what it's going to supply is the inner ring, right? So if you cut the eye in half, more or less, it's not exactly this, but the oculomotor nerve is going to supply the levator palpebrae superioris, the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique, right? So you've got like a little ring here. So if you were to cut it in half, essentially that is where the oculomotor nerve will supply those muscles. The superior oblique muscle is the trochlear nerve, or cranial nerve 4, right? So right here, more or less, it's not actually right here, it's inside the orbit, so it doesn't necessarily come to the brow. And then the abducens, or cranial nerve 6, is for the lateral rectus, and that will abduct the eye. So basically you have 3, 4, and 6, more or less. It's as a superficial visual. So the rectus muscles, and this is going to relate somewhat to the path specifically of the oculomotor nerve, the rectus muscles all connect to a common tendinous ring, which is also known as the annulus of Zinn, or the annular tendon. So essentially what that does is it wraps around the optic nerve in the back of the orbit, and that tendinous portion allows for the attachment of all of the rectus muscles, but it also allows for orderly passage of the oculomotor nerve as it enters the orbit and then goes inside of those muscles. So it's essentially on the lateral side of the orbit and then transmits to the medial side. So it kind of comes from here and then goes this way and then supplies through that area, as we already noted. And then as we said, the superior oblique is the trochlear nerve, and that's kind of coming from the back and at the top. And then the abducens is also coming through the annulus of Zinn inside and then goes over to the lateral rectus. Right, so you have all of that contained within the annulus of Zinn. So you at least can consider that if there is some form of pressure buildup, that within that region, if there is pressure on the optic nerve, if there's swelling on the optic nerve, which is at least somewhat possible, maybe not all that common, but if it's within the annular ring, then you can have compression of 3 and 6, right? If it's outside, then, or yeah, 3 and 6, if it's outside, you may have it on 4, but it's because of the locations of them and their relationship to that common tendinous ring that you may have 3 and 6 have problems together and 4 would have problems in another way. But what you've got is just that general idea. 3 is eyelid, up, down, to the middle, and spinning to the middle, right? So it's kind of almost everything in here, whereas 4 is going to take it and spin it out, and 5 or 6 rather is going to pull it away from the midline. So we have a general understanding as what those muscles and nerves do. Right. Now, if we're going to see problems with 3, as we already noted, one of the first problems you're going to see with cranial nerve 3 upon presentation of a patient is essentially a droopy eyelid or a completely closed eyelid, which is going to be called a ptosis or a ptosis, depending on how you like to pronounce that. Right. But as the image is going to show here, you're going to have different levels of ptosis. Right. So there's a mild droop, a medium droop, a bigger droop. Right. You've got these and varying measurements. Now, measurements such as 2 millimeters of droop, 3 millimeters of droop, 4 millimeters or more of droop, those are nice generalizations. The details will be different, but essentially, if you see somebody with a droopy eyelid, you can begin to believe that there's a possibility of something going on with cranial nerve 3, especially the superior branch, with respect to levator palpebrae superioris. Now, how would you differentiate if it was a problem with levator palpebrae superioris or a problem with cranial nerve 3? Well, cranial nerve 3, you would be able to test the rest of the movement. So you'd ask the eye to go up, down, to the middle, and try to spin it. It doesn't exactly go into encyclotorsion on its own when tracking, but you can start to do some of that with standard tests. But if it did all the motions, if the eyeball did all the motions and the eyelid didn't, then you would begin to suspect that the problem was with the muscle, not the nerve. That's a way to differentiate it because the nerve does have multiple functions. So you test the other functions to begin to differentiate there. Now, this isn't going to be, again, a standard thing for osteopathic practitioners to do. If you see somebody come in like this and you ask them to lift their eyelid and they can't, that would be time to refer out to an ophthalmologist or an eye doctor, generally speaking. So once you see that, it's time to send them out. But so that you understand, if you wanted to gather a little bit more clinical information, you can do so. All right. So again, as we noted, cranial nerve 3, eyelid, up, down, medial, and spin to the middle. So if there was a problem with any of those, you begin to suspect cranial nerve 3, cranial nerve 4 being the trochlear nerve. What you're going to see is essentially you're going to have an inability or some difficulty with looking up and out, or it's actually going to stay kind of up and out, right? So that you'd be able to test that. But as I said, 3 3 and 4, or sorry, 3 and 6 can kind of come together. 3 and 4 maybe less so, right, under traumatic situations. But you can test that as well. And then the abducens nerve, essentially what would happen is the person would be looking inwards, right? So they'd basically be looking at their nose because they're going to have a hard time taking the eye out, or they'd be straight ahead, right? They'd basically be looking straight ahead, and you ask them to take it out and they can't. They can take it in, but they can't take it out, right? So you may see them looking straight at their nose with the eye that has a palsy of 6, or they may be unable to take it away when asked. Right now, essentially what you would do, what the common test is an X, right? And that I think it goes like that, and then an H. So up, down, across, up, down. You have to ask them to keep their head still when you're doing that, because if they follow, if a patient is going to follow, what they will often do is follow with their head. So their eyes will start to move and then the head will follow. But if you keep the head still, then you can start to assess what the eyes are doing. So this relates well to a concept that I call relational motion. One thing stays still and one thing moves in relation to it. So if you want to test the muscles and the nerves, you need to keep the head still to see what the muscles and nerves are doing. Usually, the only one that you're really going to be able to differentiate as far as muscle and nerve is 3. Whereas if it's 4 or 6, you won't be able to differentiate if it's muscle or if it's nerve. You'll just know that the combined functions don't work because it's one nerve for one muscle, whereas with 3, it's one nerve for multiple muscles. So you can differentiate there. But basically, you have to keep their head still and have them move their eyes by tracking. Again, this is not necessarily something that an osteopathic manual practitioner would do, but they can if they want to gather information to maybe make a more informed referral. Right. As far as the trochlear nerve itself, so this is a symptom. A symptom would be double vision with vertical or torsional diplopia. So they'd see double, and it would be double this way or kind of double more or less like this, right? So things would spin a little bit. The other thing that might help you understand if it's a trochlear nerve is the head will tilt, right? So if there's a vertical problem, right? So images are going double like this, you tilt to deal with it. And if they're twisting like this, you tilt. So if somebody's having a problem with cranial nerve 4, they may come in like this, and the symptom that they would tell you about would be double vision, and they'd look like this, right? So as far as this is concerned, if it is an issue with the trochlear nerve, your correction to say a patient comes in like this and you want to fix the neck, or you want to work on the neck to deal with it, it's not necessarily going to help, because in order to see, they have to do this to adapt to the double vision. So you can work on the neck all you want, but they'll stay like this because they have to adjust to the double vision. So in a case where you keep working on the neck and or you haven't asked about the vision and they're like this and they keep coming in like this, when you actually ask about the vision, they say they see double, then you can start to assume that it's the trochlear nerve there. But osteopathic treatment or hands-on treatment is not going to have the desired effect because you haven't dealt with the vision issue or with the neural or muscular issue. Now the abducens nerve, so 6, which is going to take the eye out, what you're going to see with that is there will also be a symptom or a complaint of double vision, but the patient will turn their head to deal with it, right? So they will basically just keep turning it because it's horizontal diplopia or double vision horizontally. So you're going to see this, right? That's what you'll see. So you'll have a rotational issue with the neck, or superficially you believe that you have a rotational issue with the neck and you treat it, and they keep coming back like this because they're consistently adapting to the vision problem. So you'd have to, again, refer out to somebody to a higher level of care or a more accurate level of care for somebody who would appropriately deal with the nerve or the muscle, depending on what's going on. But this is in many ways beyond osteopathic care on most levels. There may be some assistive methodologies that can be useful, but it may not necessarily be corrected by hands-on treatment or osteopathic treatment. As far as the vascular supply, this is where, at least if there's a mechanical dysfunction and there are issues with the pressure through the vascular supply, you may have some benefit. So as far as the arteries are concerned, really what you're considering is the internal carotid artery as it then branches off and creates the ophthalmic artery, which will then have branches that will go to the extraocular muscles, right? So basically this is really where you're thinking. The internal carotid, the SCM, the angle of the jaw. We could get granular with the branches of the artery, but as I said, because we're working on motion, because we're more concerned about motion, our considerations aren't necessarily going to be on the eye as far as vasculature is concerned. It's going to be on the path of the vasculature and the places where we're likely to be able to have an impact, which is basically going to be the SCM, the upper cervical complex, the cervical complex generally, and the angle of the jaw, or the TMJ, right? So the venous drainage, you've got four vortex veins, and then they go into the, I can't remember, it should be right there. I don't remember the name, the particular name of the vein that the vortex drain into, but then they go into the cavernous sinus, so they go intracranially. So if it goes intracranially, what you are then considering as the terminal drainage point of the cranium is the internal jugular, right? So again, based on what we can access from the outside, you're considering the angle of the jaw, the SCM, the upper cervical complex, and the cervicals in general. So if you were to find any issues in any of those structures, and you had some form of eye issue and the patient was safe to treat, then you can consider doing work in those areas. Again, this is all dependent on whether or not their mechanical dysfunctions are increasing pressure on vasculature, because if they are, then you can do something. The way to find out is if the patient is safe to treat, you would then go ahead and treat them in a safe manner. And if you had a concomitant change in motion and in symptom, right? So sign being the motion, symptom being the vision issue or the muscular issue or the neural issue, as far as what we've already discussed with 3, 4, and 6 and all of the muscles contained therein, you would see some related change. Now, as far as contraindications for anything within the head or the eye, anything that will increase intraocular pressure, if there is a possible eye issue, you have to be extremely careful of. Because if you treat, you can increase intraocular pressure, and then that can cause a lot of problems for not only vision, but for the vasculature and the neurology within the orbit. So you have to be very careful. So as long as they're safe to treat, if you believe that there could be a vascular issue, or even just an issue, generally speaking, those are the areas you're thinking. Now, the other area that you're generally thinking is essentially the nose and the maxilla. So you can use the nose as a handle, then you can translate across. So you essentially keep a still head and you move the nose across. You can keep a still head and move the maxilla across, because again, those would help with pressure to whatever degree they're related to increased pressure on the vasculature in the region. But what you're really considering, or your areas of access, are the internal carotid and the internal jugular. So SCM, angle of the jaw, upper cervical, cervicals generally, and then as I added in, the nose and the maxilla as things that can alter on some small level the movement of the facial structure, which could then change some of that pressure. And because the facial structure isn't going to move very much, you would expect a very small amount of impact, because it's very likely that it's creating a small amount of impact because the facial structure doesn't move a large amount. So you're more likely to have your impact here. So as you look at the screen, the green artery basically coming through the back of the orbit is the ophthalmic, and then its branches that come off. And you can also see the reason that I'm talking about the internal carotid, the path basically goes up the SCM and essentially in and around the angle of the jaw, and then with the internal into the head. Right. As far as the internal jugular, you can't necessarily see the intracranial, so the cavernous sinus and then how it drains to the internal jugular. But what you can see is, again, you're looking at the SCM, you're looking at the angle of the jaw, you're looking at the nose, the maxilla. These are all areas that may have an impact on the orbit if there is a mechanical change, or if there's a change in motion. So that's your sign, and they relate to the symptoms. All right, so we've already talked about what those symptoms will look like. So diplopia, so double vision, specific lacks of motion or issues with motion with the eyelid, and then the movements of the eye. All right, now as far as lymphatics are concerned, lymphatics have been known about for quite a while. However, they haven't necessarily been well described. We're getting more descriptions of the lymphatics within the orbit, right? So the extraocular muscles do seem to have the presence of lymphatics. The eye seems to have some presence of lymphatics, and then there's some other tissues that maybe do, maybe don't, or they have the presence of certain cells that essentially might be able to, like lymphatics may be able to be induced there, so people may be able to grow them there. Essentially what it's pointing to, it's not a perfect way to say it, but you do have the presence in there. And for the most part, the further forward you are in the orbit, it will drain through the face. And then the further back, it will basically drain through the intracranial pathways. But again, with the lymphatics, what you're considering is essentially the jaw, right? So this is where you might consider the suprahyoid musculature or the musculature on the midline of the neck, the SCM and the cervical complex generally, and the jaw again. So you keep seeing the same areas that you may be able to have an impact if there is a mechanical dysfunction. So that's the sign that relates well to the symptom, which would be changes in function of the muscle, so the eye movements that would let you know about the muscles themselves or the nerves. Or in the case of 4 and 6, about both. You can't pick them apart as such from the outside. You'd need further diagnostics. Now, the lymphatics, as we already said, anterior, further are forward, it will come down here. Further in the orbit you are, it'll go intracranially and then down through. So as far as what might cause problems with the extraocular muscles and the cranial nerves 3, 4, and 6, what you're talking about is trauma or the presence of a neoplasm. Right, so a neoplasm is a uncontrolled growth of cells. So it could be benign, it could be malignant, so it could be cancerous or non-cancerous, but you would have something within the orbit or within even intracranially along the path of the nerves as they come into the orbit. So from the brainstem towards the orbit, if something's growing, you can then put pressure on it, and that would cause some of the problems that you would see externally as far as the signs, so the droopy eye, and then the inability for eye movements or specific eye movements. So trauma can do it because trauma can essentially jar things in the head. Also, it can create inflammation that would put pressure on these same structures in the same places, or it could be a neoplasm, so uncontrolled growth. And then very generally, as I already said, anything that increases intracranial pressure or intraorbital pressure. So you could have high blood pressure, right? So you could have tension through the neck, putting pressure on the artery, the vein, or the lymphatic. So you can have some things of that nature. Anything there would increase the pressure, then can relate to what would happen to these particular structures. Right. So if these things show up, as I've already noted several times, so what you want to do is refer out. So if you see somebody come in with one eye closed, and you ask them to open their eyelid and they can't, or they come in, they tell you they're having double vision for whatever set of reasons, or they come in looking like this, or they walk through the door like this, so they're tracking ahead, but their head's turned, you want to start to consider problems, that there may be problems with the extraocular muscles and the nerves that supply them. So you would want to refer out for those situations so that a higher level of diagnosis or a level of diagnosis that cannot occur from the outside of the body can happen. Now, if the patient is safe to treat, as I've already said, the only influence you're likely to have will be mobilizing the nasal region, as I already said. So if there is some deviation or movement for whatever set of reasons, you can keep the head still, move the nose in relation to it. You can keep the head still, move the maxilla in relation to it. You can work on the TMJ. You can work on the SCM in particular, not necessarily noted here, but you can work on the cervical muscle, so the suprahyoid and the infrahyoid muscles. You can work on the midline, right? And then also the upper cervical complex, and then the cervical complex, generally speaking. So basically what you're going to be working on with respect to these specific things is here to right kind of through here. So basically here through there, that's what you're going to consider. You're going to assess and treat with respect to what you find. If the sign, the motion problem that you identify relates well to the symptom, then you would expect some change. If they don't relate well, that's why you would have referred out, and maybe there's some other form of treatment that you cannot access through your means and your methods, right? So that's essentially what we're looking at. If you see these problems with movement, so the droopy eye, the problems with specific movements, the complaint of double vision, walking straight ahead like this, walking straight ahead like this, right? These are all signs that you want to consider referring out. If they are safe to treat, then you consider nose, essentially translation across, maxilla, angle of the jaw, TMJ, SCM, midline tissues, and then the neck, generally speaking. Those are the things where you may have some influence.